Now we'll talk about bipolar. And bipolar disorder involves extreme mood swings from episodes of mania to episodes of depression. And during their depressed phases, their moods, behaviors, and thoughts are the same as we just discussed with depression. So now we've already learned about depression, so we're really just going to focus on the mania portion of bipolar. It's not uncommon for a patient to be first diagnosed with depression, and then once they have a manic episode, the diagnosis would then be changed to bipolar. However, with depression alone, it can last for months to years, but with bipolar, the depression and really the manic phase for that matter, they are seen in cycles. With mood, each mood is going to be lasting for a while and then it's going to be changing. So they don't stay in one mood continuously like with just depression alone. So DSM-5 has listed 3 types of bipolar. Bipolar 1 is characterized as having at least one episode of mania alternating with major depression. The manic episode will last at least 1 week long and will result in excessive activity and energy. Psychosis such as hallucination and delusions may be seen during the manic phase of bipolar 1. In between the episodes of mania and depression, many people with bipolar 1, they can live a normal life. So in looking at this picture right here on your screen, they cycle from the very top of mania to the very bottom of major depression. In bipolar type 2, the patient will have repeated hypomanic episodes alternating with major depressive episodes. Hypomanic or hypomania, they are considered to be low-level mania. In bipolar 2, there will never be psychosis. In bipolar 1, they might have some psychosis. In bipolar 2, they will not have any psychosis such as the hallucinations or delusions. Bipolar 2 disorder is not usually severe enough to cause a serious impairment in occupational or social functioning. And typically, the episodes of depression will last longer than the episodes of mania. And in this third one, the cyclothymic disorder, the adult has at least 2 years of repeated hypomanic episodes, alternating with minor depressive episodes. So the hypomania and moderate depressive can be disrupted, but the highs and the lows are not as severe as with bipolar 1 and bipolar 2. So this graph is really a good visualization of the 3 different types. We just learned about depression, the signs and symptoms of those with depression. So those are going to be the same as if a patient is in the depressive phase of bipolar. So the signs and the symptoms of a patient that is in the manic phase, an important one would be the euphoric mode. This is just an overly joyous mode with cheerfulness that may be inappropriate for their circumstance. They're going to sleep less. They're not going to be concerned with performing their ADLs. They're going to have poor judgment, and a lot of times they're going to have some impulsiveness. Also, their clothing choices during the manic phase will often be flamboyant, brightly colored, attention-getting, and perhaps even sexually suggestive. So women, they're going to wear lots of makeup, lots of jewelry, and men typically wear tight, revealing muscle shirts or no shirts at all. Their speech is often loud and rapid, and they ignore any verbal or nonverbal cues that another person is giving them to indicate that the other person is waiting to say something. This here is a good visual picture of bipolar. So the nonstop physical activity and the lack of sleep and food and fluid intake in manic phase of bipolar can lead to physical exhaustion and even death if not treated. Therefore, if they're in the manic phase of bipolar for very long, it does constitute an emergency. Alright, so these are the different phases of bipolar. The first one we'll talk about is the acute phase. When a person is in the acute manic phase, they need to be more often than not hospitalized. And the plan is to focus on getting their medication stabilized and while maintaining safety. The nursing interventions are geared at, first your safety, decreasing their physical activity, because remember they're in the euphoric mode. You're going to want to increase food and fluid intake because they probably haven't been getting very much. And since they haven't been getting very much sleep, we want to try to get them about 4 to 6 hours of sleep per night as well. Now, whenever they're in the inpatient stage, it's also important to remember that we need to have consistency amongst staff. And also the staff members are needing to set the same limits with that patient through the consistency. During the continuation phase, planning focuses on maintaining adherence to the medication regimen and to prevent a relapse. Some nursing interventions could focus on stress reduction skills, substance abuse related problems, do some psychoeducational training for both the patient and the family. But the problems that occurred from their manic phase, if they were violent or reckless or just that bizarre behavior, can often leave lives shattered and the family and friends become very hurt and distant from a person with bipolar. And so remember that aspect of it as well. There's going to be long-term consequences for a patient that has their manic episodes, especially if their family and friends don't have a proper education about bipolar. So therefore, they often have some therapy, cognitive and behavioral therapy, along with medication as well. Now the maintenance phase, this is basically a little bit of the continuation phase, but you're just focusing on the prevention and relapse. Patients with bipolar, they will basically require medication pretty much of their entire life, so we just need to keep them on their plan and teach them how to basically maintain their life now that they are diagnosed with the bipolar. Lithium. Lithium is a mood stabilizer which controls episodes of acute mania, and it is used for long-term maintenance of patients with bipolar 1. So why bipolar 1? Now remember that bipolar 1, they have manic episodes. With bipolar 2, they have hypomanic episodes. And so the mania in bipolar 1 is worse. So this is, and lithium controls the acute mania. Lithium controls episodes of acute mania, and it also helps to prevent the return of mania or depression, and it decreases the incident for suicide as well. Lithium is the most effective in reducing elation, flight of ideas, irritability, and anxiety. However, the therapeutic range for lithium is very narrow, from 0.5 to 1.0. And so if the lab levels come to 1.5 or above, that is considered toxic. And there's a slide on that you'll want to look over as well. So patients who are taking lithium, they should make sure that they are drinking adequate water, which is about 2 liters per day. Drinking too little water or losing fluid through excessive sweating, vomiting, diarrhea, it actually increases the lithium level, which may result in becoming toxic. Therefore, when a patient is taking lithium and they even become sick with an illness that might cause them to have vomiting, diarrhea, it's important that we educate them that they need to go ahead and contact their physician and let them know, and the physician will then treat them to decrease their risk for toxic developing. So with that being said, it's better understood why diuretics are contraindicated, and also those with the renal impairment as well, because that kind of all relates. All right, make sure you read over that side. And these are all about lithium. And anticonvulsants, they will be given whenever lithium does not work or if a patient can't tolerate that. Haldol is the medication of choice that's given during an acute phase of mania. Some nursing interventions for a patient like bipolar. So first, like any other mental health diagnosis, we need to make sure we provide a safe environment and use therapeutic communication. We need to set limits and be consistent with those limits. Not only you individually, but the whole staff needs to do that. When the patients, when they're on the manic phase, they will be unlikely to sit down and eat. And so we need to provide finger foods for the patient to eat so they can eat while they're up and walking. So no mashed potatoes, even a chicken, they can get up and hold a chicken, and that would be good. So nothing that you need to eat with a spoon or fork. The foods, they should be really high in calories and protein, just because they're not going to eat a whole lot. And we want to promote appropriate behavior as well. Make sure you read over those.